unquestionably the most popular event we have every year is Ask the Doctors, and we're thrilled that Dr. Treon volunteered to moderate this session. We are going to have mics, and roughly speaking, Dr. Treon's he has about 57 pre-written questions, but he's going to alternate roughly from one of the questions that was handed in to somebody in the audience who has a question for him. So we'll keep this going, and I'm thrilled to bring Dr. Treon back on the podium and thank him very much for his time and his effort and participating with us. What a great partner.
Well, as Paul said, this tends to be one of the most exciting sessions, although how can we say that? I think every one of our sessions has been very exciting. But I want to, yes, right. But I want to introduce several of my friends and colleagues who have volunteered their time to be with us today to answer your questions, and we've already gotten quite a few. But let's start off by asking Professor Shirley Dessau from London to join us. Shirley? Shirley has been truly an luminary in our field. She chaired the international workshop on Waldenstroms when we held it in London, one of our most successful and beautiful meetings. In fact, closing ceremonies for that meeting were held inside the UK Parliament, and it was one of the most amazing events that I was ever able to attend. We were able to resurrect actually Winston Churchill and bring him to our closing ceremonies to offer comments, and I loved really his speech, which was, we'll fight, Waldenstroms in the laboratories, in the clinics. But it was a very inspirational speech. I also want to now invite up here Yazir Sawawa, who is from the University of Ohio State, right? The Ohio State. And also very active in the WMNet. He has a true passion for Waldenstroms, and we're so grateful to have him join us. And of course, needing no real introduction is Jorge Castillo, who is the clinical director of the Bing Center. And Jorge also, for those of you who may or may not know, chaired the international workshop on Waldenstroms when it was held in New York City. And I do remember the closing events of that meeting were held at the United Nations. And that was also quite a spectacular meeting. That was just before COVID hit, but it left us really lingering with much hope and thought. Unfortunately, our other chair of that meeting, Leah Palumba, who was supposed to be with us today, is ill. And we wish her well. She remained in New York City where she's recuperating, and we wish her well. So I already have received a number of questions. I think it's very important before we start off to say this is really an educational session. No one's going to be offering specific medical advice for someone because obviously you need to know a lot more about a patient so that you can construe an answer as specific medical advice. So please think about this really as being an educational event. We try to keep to questions that most of us can relate to, so we try to avoid specific mentions around personal healthcare data. We try to avoid that because of the HIPAA laws. And we're going to try to alternate between taking questions from the floor. We have microphones that are going to be running around for your use. And I'll be using the questions that have already been pre-submitted in the alternative. And this way we can keep it going. So we have actually some really exciting questions. And I think the first one I want to start off with is one that we've debated about at our international workshops. And that revolves around, do I use a BTK inhibitor up front like zanubrutinib or ibrutinib, or should I be using bendamustine and rituximab? This is from someone who says that it's a case of Waldenstrom's with no comorbidities. And I'm just wondering what your take on this would be in terms of what your choice would be and why. And maybe, Shirley, you could start us off?
Okay, thanks, Steve. Yeah, that is a question we've debated, and actually we did again in the European Consortium meeting, which was a couple of weeks ago. So BR versus a long-term continuous oral therapy, it's a big question. One that is answered in some questions before you even consider the science, because in the UK, for example, we cannot give a BTK inhibitor up front. It's not permitted by our funding rules. But notwithstanding that, there are pros and cons. I think bendamustine, which is a traditional chemotherapy agent, cytotoxic, works on the DNA of cells. In WM, it's really difficult because the cells grow very slowly. They don't cycle very rapidly. Any kind of chemotherapy agent will kind of knock them back, but it won't really achieve taking out every last one. By adding rituximab to that, which is a target CD20 proteins on B cells, that can add to the benefit. The good thing about BAR is that you can give it for 4 or 6 cycles. Each cycle is a month, and then it's finished. Yesterday there was a bit of a discussion about do we continue with rituximab maintenance, and the consensus is no. So that is a short-term defined therapy. It is a good way of clearing the marrow, and if we think about WM, it's a marrow-based disease. It has a good record for really depleting WM cells, which is helpful and makes a lot of sense. The main side effects are that it can suppress the immune system quite globally for months and perhaps even a couple of years. Now that plays out differently in different people. Some people do end up having infections and very low antibody levels. Others are actually pretty okay. And that's one of the reasons we tend to give 4 cycles instead of 6 when we can, if someone has low levels of disease. BTK inhibitors, on the other hand, is long-term, continuous, very well tolerated in general, but in my practice, we have over 100 patients on BTKIs in WM. You can see that there is a creepage of some side effects in many patients over time, and that is one of the other issues. And I think it's more a treatment that inhibits WM rather than clearing cells away. So it's very good at decimating the IgM problems, raising the hemoglobin. So I think if someone has no comorbidities, in my practice, partly because of rules as well, but even if there weren't those rules, actually, I would probably go with bendamustine and rituximab.
Okay, thank you, Shirley. Yazir?
Yeah, very common question, very good question. I offered both treatments for most my patients, sit down with them and discuss the pros and cons. This is a very nice summary by Dr. Shah. I would say a few other things. Cost sometimes can be an issue for the BTKI. There could be a co-payment, and if patients are going to stay on the treatment for several years, that can be an issue, whereas for BR, most patients don't have a co-payment. That can be an advantage. But it's mostly around indefinite treatment with BTKI, keep them on the BTKI for as long as it's working versus 4 to 6 months of treatment with BR. And think in terms of efficacy, most experts would think that they are both equally efficacious. It's just about the different side effects, the different treatment logistics and duration. So it's a discussion with the patient. I commonly tell patients by the end of the clinic visit, you don't have to decide right now, go home, think about the pros and cons of each treatment. We'll talk next week and pick the best treatment for you. But either one, for most patients, is appropriate. It's just what's best for you, given your circumstances and the side effect and the treatment schedule.
Ori?
Yeah, no, I think that's exactly right. In other conditions that are more common, like myeloma, CLL, conditions of that nature, there are big randomized studies comparing one treatment over the other. So in terms of populations that are very well balanced, you understand a little bit better, what the differences between treatments are. The issue with these treatments currently is that we have bendamustine and rituximab, and there's a study on that, but there's no comparative study against, zanubrutinib or ibrutinib. So in that lack of comparison just makes it a little bit more difficult for us to categorically say, oh, there is superiority or not superiority, or they're the same or not the same. If we look at the experience with bendamustine and rituximab or zanubrutinib or ibrutinib independently, the depth of the response is very similar, the duration of the benefit is very similar. So, I mean, in terms of, if you just look at the numbers alone, really there are no major differences. Again, acknowledging that there are no formal comparisons, right? And that sometimes is a little bit of an issue. So yeah, I tend to have these discussions with patients. So in my practice, the patients who like, the idea of getting exposed to chemoimmunotherapy or bendamustine and rituximab, they like the idea that is killing the cells, that they like the idea that it's a finite type of treatment, and that's what they feel more appeal towards. The patients who tend to choose BTK inhibitors, they choose it because of it's just very few pills. I'm already taking pills. I don't really mind taking pills indefinitely. I think it allows patients to have a freer quality of life or a lifestyle a little bit as well. So there are very different features. And again, I think it's a choice that the patient actually has to make. We provide the pros and the cons of each approach, and then what it makes sense on those patients in a specific setting. So if I think about my practice, it could differ from other people's practices. I would say probably about 2/3 of patients end up choosing a BTK inhibitor in our practice. About a third of patients tend to choose a chemotherapeutic agent in our practice, and that's our numbers. I think if you go to Ohio State or Mayo or another American institution, I think that those proportions might be a little bit different, right? But I agree. I mean, I think the statement here is none of them is superior or inferior than the other. They are just different.
I had a few questions since the topic of bendamustine is now, so important in our field, when we use it and how we use it. We had the report from the French Philo group at the workshop in Prague, where they reported out on the long-term toxicities that they encountered. And among the toxicities that they reported was that almost half the patients had sustained suppression of their blood counts, cytopenias. And we also saw a fair amount of malignancies, including what might have been secondary acute leukemia and myelodysplasia. I'm wondering, how do you factor that in when you're talking to a patient about, pros and cons of BTK inhibitors versus bendamustine? How do you approach the conversation around the potential? Although, there are a lot of footnotes and caveats when you see these data, but how do you approach, the discussion about long-term toxicities and risk? And maybe ask Shirley to go first.
Yeah, I think that's a really key observation, because it is true. Bendamustine can upset the bone marrow elements, not just the immune system, but also some of the other blood-producing cells. And that's one of the reasons we, in our practice, limit the bendamustine dose if we can. It's worth mentioning there is another regimen called DRC, dexamethasone, rituximab, and cyclophosphamide, which is quite widely used in Europe, perhaps more so than the United States. It's also a 4.5-month treatment duration, 6 cycles, 3 weeks per cycle. Cyclophosphamide has been in cancer treatment for decades and decades. It can have problems with nausea and other things, but it's less likely perhaps to cause some of those adverse effects as bendamustine does. So I think that is important. I think one of the ways we're trying to tackle this with BR is to look at the genetic signatures within the marrow, not just the WM, but also some of the other compartments, because we can increasingly study those using genetic analysis. And if we find that there are some risk factors for progression of other conditions, we would really think twice about going down the bendamustine route. But I think limiting the dose is important, but there is the DRC regimen. So I think, yeah, it's an open question, and that is why we need to keep open-minded about it and see what further evidence comes through from research.
Yazir, how do you introduce this to your patient conversations about risk-benefit?
Yeah, I mean, these are some of the most important risks with bendamustine. I usually tell patients infections is really what I worry the most about with bendamustine. So we talk about vaccines, about avoiding activities that could potentially increase the risk of infection. And unfortunately, the risk of infection is not only during the 4 to 6 months while they're on treatment, but also for several months or maybe even a couple of years after. So that's something that might be, that they have to take into consideration when we're choosing between bendamustine and BTKI. And this is not saying that BTKI don't increase the risk of infection. They do. And the Waldenstrom itself, of course, does increase the risk of infection. Fortunately, the risk of second cancers or other cancers, fortunately, the risk is low. This is one of the reasons why we never do more than 6 cycles of bendamustine at our institution. I think most sites in the US right now. And it's also why sometimes we might stop at 4 or 5 cycles if we're running into problems with very low blood counts that require treatment delays, for example. And it's also why sometimes I would use a lower dose, especially for older patients. Rather than giving the full dose, I might reduce it by 25% or so, because I'm worried about persistent low blood counts in those patients. But yeah, these two secondary malignancies, fortunately, are rare, but when they happen, they have important consequences. So it's a risk definitely worth discussing with the patient. Infections and low blood counts are relatively common, but I think there are measures we can do to lower the risks and deal with them when they happen.
Ori?
Yeah, I mean, so the risk of myelodysplasia in any myeloid problem, has been cited anywhere between 1% and 2%. So it's relatively low, but once you see one, and these are secondary processes, so they tend to be harder to treat than the regular myelodysplasias or leukemias that happen in the general population. So yeah, and I think the way that guides at least my approach is individuals who are younger, and the definition of younger changes as I'm getting older. That we try to hopefully avoid exposing younger people to immunotherapy, for example. So just to give an example of how we can adjust a little bit the approach, right? In this case that you mentioned, somebody without comorbidities, you didn't mention it was a younger patient, so I'm thinking that previous patients in their late 60s, 70s, like the average, Waldenstrom patient in the country. So, for that reason, I think it's reasonable to either or. Will be a younger individual in the 50s, probably I will try to avoid chemotherapy exposure in that setting. But on the other hand, you can say, well, but maybe this is a person who will be the longer than on a BTK inhibitor, right? So it's always a conversation to be had. Now we have clinical trials who are actually combining both, combining a little bit of the chemotherapy and a little bit of the BTK inhibitors. And hopefully, that will induce a deeper, longer response in some patients. And if that's the case, you can still use them both, but later, right? So I think it's an important development that we will see what happens with those trials.
Yeah, Shirley, you did mention that in your practice you tend to go with 4 cycles of bendamustine, but throughout Europe and in Canada, the practice is usually 6 cycles of bendamustine Rituxan. Here in the US it can be quite variable, although I think most folks use 4 cycles. And I was wondering, for you, Yazir, how many cycles do you usually use of Benda-R?
I usually aim for 6, but I have very low threshold to stop earlier if we run into issues with delayed blood counts or infections or really any complications. I don't feel bad if we have to stop at 4 or 5.
It's the same. I mean, I typically say, when I give you 4 for sure, or more likely you're going to get 4. And then depending on the depth of response and the tolerability and things of that nature, we can decide if we can go 5 and 6. There are some situations in which I really want to continue to protect  'a kidney, which happens very rarely in patients with Waldenstrom, some other conditions. So yeah, I think 4 is at the minimum. And then I think in our practice, maybe I can have 50-50 patients end up getting 4 or 6. And that's our distribution.
Sure.
I mean, we tend to give 4 benders, but 6 Rs. Because if you think about tumor kill, it's usually a sort of it's a curve, isn't it? And so you start off with a big burden, but when you get after 4 cycles, hopefully you're looking at a smaller tail of disease. And I feel then you could continue with the rituximab for 2 more cycles, but the bender's done its job probably by then.
Are there patients, when you're considering BTK inhibitors versus bendamustine, are there patients where you would want to see bendamustine being your choice of therapy? Is there any morbidity that you feel it's better to use bendamustine, Rituxan over BTK inhibitor? And that's important because we have a lot of treatment-naive people here in the audience who are considering these options. So, Yazir, maybe we can start with you on this one.
It's not a comorbidity with amyloidosis. The data with BTKI is not as good as with bendamustine, so that's usually one scenario where I will favor bendamustine rituximab over BTKI. If they're, this is fortunately uncommon these days, but if they're in Coumadin for potentially a valve in the heart that requires Coumadin and no any other blood thinner, the combination of BTKI and Coumadin or warfarin can be very risky. The risk of bleeding can be very high. You also have to be careful with bendamustine because it's also going to lower the platelet count, but it's, in general, I think it might be easier to deal with than a BTKI. Patients with history of bleeding in the brain, these can also be, in general, hard to give them BTKI because of the risk of bleeding again. So that might be another scenario where I might maybe favor bendamustine, maybe with a lower dose and maybe for 4 cycles rather than 6. These are a few things that just come to mind.
Yeah, I agree. I think amyloidosis was the big one. That's the one that wasn't mentioned. With BTK inhibitors, it seems to me that the response is not as good, number one, and there's more toxicity as well. A lot of patients with amyloidosis do have some heart issues, and with the potential risk of arrhythmias that the BTK inhibitors may have, and sometimes it's not a good cocktail right there. So yeah, amyloidosis for me is the big one, and the ones that Jesse mentioned. I think it's a pretty complete list. Sometimes in patients who have really extensive extramedullary disease, sometimes we tend to choose chemotherapy over BTK inhibitors. But again, fortunately, that's not a very common situation.
Yeah, I think another area might be cryoglobulinemia because you get this vasculitis, and I think sometimes it calls for the power of chemotherapy, and I think bendamustine can be good, cyclo as well. Bulky disease, I agree. I think, as I said before, I don't think that BTKIs are really good at getting rid of bulk very quickly. And we've got a cluster of patients who've actually had bone infiltration, which is painful. And we've had 2 or 3 at least who've been on BTKIs. IgMs have come down really well, but their bone disease has not improved. And we've then had to switch them to BR, and actually that has made the difference.
So since we're on the topic of bendamustine, Rituxan, one of the questions that we received is in about 5 to 10% of bendamustine Rituxan patients, shingles can develop. Why aren't all Benda-R patients getting an antiviral, is this question. And should T cells be tested after treatment to assess the risk of shingles? I have my thoughts on this, but actually I'd love to hear from the experts, and maybe we could start with Shirley.
Okay,
it's a good question, by the way, so thank you, whoever asked it. Yeah.
So we always give acyclovir and cotrimoxazole prophylaxis with bendamustine and Ritux, and indeed with BTKIs. When it comes to stopping, we are guided by the lymphocyte count generally, because sometimes the lymphocyte count is like 0 point something for months afterwards. So people tend to think maybe after 6 months you can stop, but if the lymphocyte count is in your boots, we would tend to continue anyway. And if it's getting to be borderline, we may check the subsets to help guide our practice, T-cell subsets. There is also, of course, the Shingrix vaccine, which we get our over 70s, I think, get as part of the vaccination program. That's a killed shingles vaccine, so it's safe for patients with WM. The thing about vaccines is that when someone is immunosuppressed and then they get further immunosuppressed, it's really hard to know what benefit a vaccine gives. But we do advise getting whatever benefit you can. And the timing of that can be difficult, because if someone really needs treatment quickly, then you can't hang around. But sometimes you can build up to vaccinating. But yeah, we tend to just give regular acyclovir and cotrimoxazole for what it's worth. Yeah.
Yeah, I recommend acyclovir or valcyclovir for all my patients on bendamustine while on treatment and for at least 6 months after. In my mind, this is a requirement. I also recommend Bactrim as well. That's a prophylaxis for certain types of pneumonias with bendamustine, again, for all patients.
All right.
Actually, I do tend to recommend acyclovir or valacyclovir. I do not recommend Bactrim, typically in our patients. And in patients who are getting BTK inhibitors, I do not recommend any prophylaxis whatsoever. There was a study that an infectious disease fellow did when he came to Dana-Farber, and he looked at the risk of pneumocystis carinii and or invasive, fungus infections in CLL patients treated with BTK inhibitors and Waldenstrom patients treated with BTK inhibitors. So he did two, not comparative, just independent studies. So one with the Jennifer Brown group and one with our group. And the discoveries were very diverse in terms of the risk. So the risk of pneumocystis and fungal infections was way much higher on the CLL patients on ibrutinib compared to the Waldenstrom patients on ibrutinib. From all the patients that we had at that time, they were easy, I think it were probably about 250 with long follow-up, some of them up to 7 years. There was one possible infectious condition. No pneumocystis were seen. So based on that, I really do not provide any prophylaxis to BTK, on BTK inhibitors specifically.
No, I think that's, I think if you look at the data, that makes a lot of sense. And I think we've stuck to this practice because it varies a little bit in different hospitals, but we have stuck to it. I think beyond the data, there are a couple of circumstances where I think it is important. So if someone has already had shingles and then they start on this drug, then probably I would give them in that circumstance.
With that, I agree fully.
And likewise, if someone's been on steroids for any length of time, because for other things, that seems to increase the risk of these kind of infections. So that would buck the trend a little bit as well.
I agree. In those scenarios, I'll provide that too.
Yeah, I think that's actually a good point, that there's data also from other lymphomas where if you're on steroids like prednisone, along with a BTK inhibitor, you may be at higher risk for fungal infection. And so make sure you're always in touch with your doctor, because sometimes you've got two different doctors, your oncologist and your rheumatologist, that may be offering you, these two therapies, but it's always important for all the doctors to be involved to know what you're receiving.
What I want to clarify is I do get a lot of patients that come to see me. They're already on prophylaxis. I don't stop them. I don't stop the prophylaxis. If you're already on prophylaxis and I say, well, your doctor feels comfortable, I'm not the one who's going to stop the prophylaxis, even though I don't use it in my practice. So I think that really shows that, it's sometimes a matter of style. I don't think clearly there's one approach that is a mistake and the other one is the right approach, right? I think there's a series of approaches that
Absolutely.
you can follow.
And the other thing, it is burdensome to take these extra medicines.
Yes.
I really get that. And I think, particularly I think you call it Bactrim. I hear they're really big tablets. And it's difficult to remember when you're on a therapy for years and years.
And you can have sometimes complications with Bactrim, including reduced blood counts. So, you have to be judicious when to use it. You brought up Shingrix vaccine, and I'm just wondering, I just want to poll the other two members. So you offer it to your patients irrespective, right?
So there's a sort of a national health system where I forget the actual threshold, it might be 60, 65, but they are all people of that age, over that age, are offered it anyway.
And how do you feel about Shingrix? Should patients be getting Shingrix?
Yeah, anybody over 50 qualifies based on the CDC recommendations. So
right.
I offer it to anybody who's older than 50.
Yeah, same thing. And if a patient is on observation and we're anticipating starting chemo in the near future, that would be a good time to get the vaccine before we actually do treatment.
Great. Now, let's ask the audience for questions. I see a hand all the way down there by the wall, on the other side of the wall.
Hi, my question is more related on the same subject as you guys were talking, but it's more towards neuropathy related. My husband has drop foot, and we went one time to get a device. It's called a functional electrical stimulation, Binus L300. It's so in general, we were told because he's got cancer, he shouldn't use something like that. So along with that, the other part of my question is, what about things like TENS and electrical muscle stimulation? Are these things that he needs to avoid due to the, Waldenstrom's? Would that, create more cancer or aggravate it, or?
Yeah, those are good questions, and we're always fielded these questions about medical devices and sort of keeping it general about medical devices and how, patients with Waldenstrom's should be considered. And I think it varies. I'm not familiar with any literature that suggests that these devices that you mentioned are associated with cancer risk, but in some cases, they may provide benefit to the patient and their neuropathy. But neuropathy in Waldenstrom's is a very complicated subject. You can have neuropathy because of many different mechanistic reasons. Your IgM can cause it, amyloid can cause it, cryoglobulins can cause it. We have this other entity called small fiber neuropathy, which we don't understand, quite honestly. Maybe there's been some evolution in our knowledge on this. But being able to treat sometimes patients symptomatically outside of treating the disease is an option. And we consider this on a case-by-case basis. I wondered if our panel had any other thoughts maybe to offer on this topic.
I agree. I don't think there's any specific contraindication to any of those. Again, as you mentioned, it is a symptomatic management. I don't think it's curing or regenerating the nerves. I don't think that's what's happening precisely. It's maybe helping the symptoms a bit, and if it works, then great. There's a lot of these options, and again, those are hit or miss situations. Sometimes they do help, sometimes they don't, depending on the patient. So I do not discourage patients from trying different things as long as they are not counteracting the effect of the treatments that they're on for the Waldenstrom's or things of that nature. But yeah, I don't think there's a specific contraindication based on the fact that it might create more cancer.
Yeah, I agree.
Okay. All right, we got agreement here. Good.
Consensus.
We have another question, please.
I do. The CDC says that everybody over 50 years of age who have any weakened immune system should have Shingrix. And we say that in the IWMF, that every patient has that.
Yeah.
Agreed.
Yeah, we agree. Okay. This is actually an interesting question that comes up a fair amount, and that is whether we should consider adding rituximab to a BTK inhibitor when we're offering a BTK inhibitor. And do we have sufficient data to know if this really is advantageous over offering a BTK inhibitor alone? Shirley?
So the INNOVATE study looked at the MYD88 wild type, and it seemed that adding Ritux to ibrutinib could help to overcome the resistance. I think it sounds doesn't sound like a bad idea, because you can, when you combine those two agents, I think toxicity is really manageable. In my practice, I can't actually do that, but I think there's good intellectual basis for doing that. And of course, as for adding ibrutinib to other agents, there are ongoing trials at the moment.
Yeah, so most of the data is with ibrutinib. I'm not aware of any data in zanubrutinib, and it's not something I routinely do where I combine zanubrutinib and rituximab, but if there's a suboptimal response to zanubrutinib, maybe because of high-risk disease, I think it's something worth discussing and considering, but it's not something I routinely do.
Yeah, I mean, again, the issue with Innovate is that it compared ibrutinib rituximab versus rituximab and placebo, right? So it didn't have an ibrutinib arm that would have been ideal to understand really what the addition of rituximab would have been. The comparative arm should have been ibrutinib alone without rituximab, but that arm was not part of that study. So that really doesn't help much. We are completing an analysis. Many years later, we were able to collect some of the data from the Innovate study and collected some of the data from the prospective studies with ibrutinib and kind of getting a sense of how the ibrutinib plus rituximab combination works. But again, it's a retrospective study. It's not a prospective study per se. And we presented these findings. It looks like maybe in the CXCR4 mutated patients, there is a benefit of adding the rituximab to ibrutinib specifically in that population. The progression kind of improves in that group compared to it didn't improve when we just give it in ibrutinib alone in patients with CXCR4 mutations. So I think that may be the population that will benefit. The problem is, and based on the data that we have created at Dana-Farber from the laboratory, is that it's not all the CXCR4 mutations. We have some specific subtypes called nonsense. We have other subtypes called frame shift. And if you separate them like that, it looks like nonsense maybe do a little bit less well with ibrutinib compared to frame shift. And if you look at the nonsense, depending if you have more than 20% and less than 20% mutational burden, so there's a lot of nitpicking there. So clinically speaking, how do I use that information? I basically start the patient on the BTK inhibitor. I used to use ibrutinib. And if I didn't see a great response very quick within 3-4 months, then at that moment I will consider adding rituximab in that setting. But again, following that paradigm, it's a very small group of people who I end up adding rituximab in that setting specifically. I have not added rituximab to zanubrutinib in my practice at this time.
Can I ask you, Jorge? So sometimes we can only give zanubrutinib after prior therapy. So in order to get people to Zanu, we sometimes give 4 Rs. Do you think that there's some, if you give rituximab as a starter and do Zanu later, do you think there's going to be any advantage somehow?
I do not have any problems with the combination, right? I think if you combine zanubrutinib and rituximab, I think it's going to be good and effective. I don't know how much more effective over zanubrutinib alone because we don't have that study. And maybe there's a subgroup of people that will benefit from something of that nature, but we don't know which subgroup of patients is, right? So I don't think it's a bad thing. I don't think it's going to be damaging the patient. So I think if anything, maybe providing some benefit. It's just, to me, it's unclear which group of patients are benefiting from something.
Shirley, it's a very good question because you might theorize the other way around might be the better way to prevent the IgM flare, which we see in about half of all patients. And I think this is an important study that needs to be done, but we did see in the Innovate study that the IgM flare rate went from 50% down to 8% when the patients got the combination of ibrutinib and rituximab. So it is a great thought. It should be considered with zanubrutinib as a potential study. But what brings me now around, as you mentioned it earlier, Jorge, is now we're looking at combinations of zanubrutinib with bendamustine and rituxan. We've seen the Brahms study results with acalabrutinib, benda-R. How much of what we're doing now is academic because we're actually moving towards a field of defined treatment duration, actually taking advantage of all these active drugs?
Yeah, I think, and I say this, I have said this a few times in the past, the standard clinical care of patients, the main goal is to improve the quality of life of the patients. I think it's the way we operate, and I think that we have been very successful at taking care of patients, partnering with patients in that specific setting. Clinical trials, we're still looking for the same thing, right? But in trials, the agenda is just a little bit different. We're always trying to push towards something. And I think what we have been trying to do for the last years is to try to induce deeper responses, right? try to bring the patients into a place in which maybe they can talk about a complete remission, right? And that's what these combinations are trying to do. So I think in clinical trials, I think it's valid to aim, for these outcomes. However, in clinical care, I think is still the most important aspect of things is the quality of life of the patient.
Okay, I've got for you one good genomic question. And that is, we received many questions about TP53 mutations. It was discussed yesterday, but we would like a quick recap. We understand it's generally related to previous therapy, but can it occur without previous therapy? And we have some biomarker data that was offered as part of ASPEN. Yazir, you look like you're ready for this question, so go for it.
Yeah, so it can be seen at diagnosis or without patients being exposed to previous treatments. Fortunately, it's very uncommon, probably less than 5%, maybe close to 3% based on the data we have. A lot of it is from Dana-Farber. So in general, at diagnosis, it's very uncommon. It tends to become a little bit more common as patients go through different lines of treatment. TP53 is also present in almost all other types of cancer, so it's not just unique to Waldenstrom, and it's generally associated with poor responses to treatment or shorter responses. That doesn't mean that a patient with Waldenstrom and TP53 is not going to respond, and sometimes even respond for a long period of time, but on average, in general, patients with those mutations in their lymphomas tend to respond again poorer and for shorter duration than those without the mutation. I think this is one area where we need to have just better treatments, and combination treatments or novel agents like bispecifics or CAR-T, for example, might be the way to go in the future.
Shirley?
And I'll just step in to say, well, the TP53, it's a tumor suppressor gene. And so if its job in the body is to suppress the formation of new cancer cells, which unfortunately happens, it does happen quite a lot in cell division anyway, so it's a mechanism that's there as a safety net. So when it's deleted or interfered with, i.e. mutated, that is when it doesn't do the suppression so well. And that is when, if that is present, the worry is that it could make the whole tumor less stable and less responsive to therapy. But I think it's also important to realize that when we look for TP53 in the bone marrow, it depends how you analyze the bone marrow. So if you do just take the bone marrow and do a TP53 on it, you could be finding it in the non-WM cells. So one has to be very careful with the analysis, and that is something that the scientific community are looking to do. Ideally, you should select the WM cells and do the TP53 in them, but many labs don't have the capacity to do that routinely. So there are a lot of caveats with TP53, but in general, when it's around, we do think about, look, what do we do that's a bit more than standard therapy, just to get ahead of the game, kind of thing.
Yeah, well said.
Yeah, I agree fully. And again, we don't understand really well, what the function of TP53 is when it's purely in the WM cells versus in the outside of WM cells, and does it really matter, right? So I think that's a part of the research that we need to do to understand that a little bit better. Now, even though as a group, the patients with these mutations in TP53 might have, less durable responses, doesn't mean that they do not respond to treatment. So some patients will benefit from treatments. But it does seem to me that in terms of chemotherapy, there's a bit of resistance. In terms of BTK inhibitors, there's also a bit of resistance. So I think it's a very interesting group that we need to investigate further. In CLL, for example, there have been studies specifically on CLL patients with TP53 mutations and try to understand how to treat those patients better. I think that's something that we are thinking on doing, but obviously with the number of patients with Waldenstrom's being more reduced, then it's a more challenging population. So it has to be a multi-center, multinational study.
But let me ask you, today, here and now, you have a patient that comes to you and they have a TP53 mutation and they haven't received therapy, so they're considered high risk. Would this influence what type of therapy you would select?
For me, it does up to some degree. I don't think it's contraindication for any treatment. So I want to clarify that. I think any treatment, if the patient would like to have chemotherapy, for example, I think he can have it, or this patient can have it, but it will be less preferred to my list. So in my list will be a BTK inhibitor more preferred, probably a proteasome inhibitor second, and maybe immunotherapy third in that specific line of approach. If for some reason the patient will be very much against BTK or proteasome inhibitor, I think the patient will do okay with immunotherapy, but it's my less preferred option.
There?
Yeah, I agree. I think one of the advantages of bendamustine is that you're getting treatment for 4 to 6 months and hoping you'll be in a remission or response for 6, 7, or longer years. But if with TP53, you just worry that the remission is going to be much shorter, so the biggest advantage of bendamustine might be lost. Not saying that I don't offer it or recommend it to patients, but I might favor BTKI in general. And this is one scenario where, if there's a good clinical trial, I would definitely, recommend it even higher than for the average patient, because we definitely need to prove on the outcomes that we achieve with the current treatments we have.
Shirley?
Yeah, I mean, I think one thing to bear in mind is that any of these mutations or the presence or absence, it's not a black and white thing. So in any one individual, it's not like the death knell for someone. There are so many nuances, so we shouldn't make assumptions. If you get a bone marrow and they say you have a TP53 mutation, because of all the things we've discussed, it's a relative concern, but it's not an absolute one, because we don't know everything about TP53 in WM. So we do follow principles, and in our practice, because we can't use a BTK up front, we would certainly limit even more perhaps the bendamustine or cyclo. We might make an active choice to transition to BTKI quite early, but equally we don't panic, because we don't want to work our way through lots of therapies and use them up, because many times once you've used something, you can't really go back to it. So I think the main thing is not to panic, and there's a lot of effort going into this across the community, in labs across the world, and I think in the next year or two we'll know a lot more, and then we'll be able to give more educated advice about this.
Yeah, my take on this is I'm very concerned about TP53, and when you see the mutation, you do see that patients have shorter survival. And the Aspen study, if anything, taught us that prior therapy did impact the acquisition of TP53 mutations. Now, it's true also, the way it was tested wasn't our ideal way of testing. As Shirley said, they took all of the bone marrow and they looked for, all of the cells in the bone marrow to look for TP53. But nonetheless, it was really a poor harbinger, and it was associated more so with people that had seen prior therapy. Most of those people had seen an alkylator drug like bendamustine or cyclophosphamide or even fludarabine. So I do remain quite concerned. We are now, and again, thanks to the IWMF and private philanthropy, we've actually been looking in our lab at patients that have been previously treated to see, in fact, if the TP53 mutation rate is associated more so with alkylator drugs compared to non-alkylator drugs, alkylators being bendamustine and cyclophosphamide. And we do see a trend, in fact, that you do see a higher incidence of TP53. And this is actually in the tumor cells, because we've isolated the tumor cells, just like Shirley was saying. So I think as we evolve our understanding, this could be practice, changing when we see certain patterns of TP53 mutation rates occur with prior treatment exposures. But I want to thank the IWMF, because this is, in fact, a very important question and for funding this work. Now I'm going to go on to some other more exciting questions, but I want to see if the audience has one. I see 2 questions over here, so maybe...
I have one.
Wait, where?
Back here.
Okay, super. Somebody's got already the microphone, so let's...
I have the microphone.
You have the microphone. Go for it. Whoever's got the microphone gets
me.
priority.
It's me. So
Please.
this is a follow-up question to the TP53 mutation.
Yes.
So when it says that it is the gene suppressor, how does that manifest itself in WM? So you were talking about, having previous treatment or not. How does it manifest itself in WM? What is it? Because if it was Leaf-Remini, it's totally different. and you would be doing scans regularly to monitor that. How does it manifest itself in WM? What does it look like?
Yazir, I think, really hit the nail on the head by, first of all, saying that this isn't just Waldenstrom's only problem. You see this across many different cancers. You see it in myeloma, you see it in CLL, but usually it has a poor harbinger in terms of how patients are going to respond to therapy and what type of therapy they respond to. There's a lot of footnotes that go with this, including whether or not you've actually have a mutation in TP53, or if you've lost the chromosome that contains TP53. That tends to be worse, actually, from most of the models that are out there, that if you lose the chunk of chromosome where TP53 is sitting on. And then there's controversy about the level of TP53 involvement that you see, what percentage of the tumor cells actually have the mutation. This has been important in CLL as well as in myeloma. In Waldenstrom's, it might be very different because we see even a little bit of TP53 expression seems to affect survival. But I think it is a complicated question. The way we're going to sort this out is important, but therapeutics can impact TP53 outcomes. We know from the ASPEN study, and maybe one of you may want to talk about the ASPEN study, how patients did on Zanu versus ibrutinib who had TP53.
So the ASPEN study randomized 100 patients to zanubrutinib and 100 patients approximately to ibrutinib. And after the study was completed, there were no statistical differences between the groups in terms of the benefit that they obtained. Both treatments seemed to be very much equivalent, very effective. They looked at different mutations that might have actually affected the outcomes on these patients. And actually, TP53 came up to one of them. So TP53 affected the outcome in patients on ibrutinib as well as the patients on zanubrutinib. Again, not like these medications don't work. I mean, they work very well, but the benefits just were a little less evident in patients with these mutations.
Sure.
I mean, just in terms of the question about how it manifests, there may be I get an impression that sometimes the disease behaves a little more aggressively in patients, and sometimes you get, when patients present with quite maybe bulky disease, or some of the cells are, when you look down the microscope, they're a little more angry looking, if you like. I think that would influence my treatment if I know as well there's a TP53 mutation, because that clinical impression plays into our decision making in that individual patient, I think.
Yeah. Any other comments? No. No. So what you'll see is based on the consensus paper that just came out from the last Waldenstrom's workshop is that, in fact, we now do advocate TP53 testing. And it should be repeated if somebody needs to be treated again, because it's possible that it might have been acquired as a result of therapy. But I think all the answers that have been offered here are spot on in terms of, response to therapies being impacted by TP53. We saw that with both of the BTK inhibitors in the ASPEN study. And I think the durability of these responses also is impacted.
I think the patient mentioned the Li-Fraumeni syndrome. Just to clarify that, the mutations that we're talking about right now in Waldenstrom's, in CLL and myeloma, those are acquired mutations. That means they are not in the patient's eggs or sperm or skin or saliva. They are only in the cancer cells, and that's called acquired mutations. Li-Fraumeni is a different condition in which the patients have these TP53 mutations, but they are born with these mutations, right? Congenital mutations, and so that it's a different syndrome that what we're talking about here, a different type of mutation that we're talking about here.
Okay, we need to take a few more questions. Please, sir.
Looking down the road of 5 years, 10 years, are there new types of treatments that patients will be taking, or will the focus be on optimizing, improving what's in place?
Yes and yes, but let's actually, if I can just rephrase your question just a little bit, what therapies are you most excited about in the next 5 years? And let's not talk about combinations because we've already gone over that, but what are the specific drugs that you're going to get excited about that you anticipate in the next 5 years are going to be very meaningful to Waldenstrom patients? Yazir, you're ready to go.
Yeah.
So.
I think a lot of exciting new treatments. You might have heard about the BTK degraders. I think that's a class of drugs that seems to be very active in Waldenstrom and tolerated well as well. So that's very exciting. I think you might also heard about the bispecific antibodies. These have already shown very good results in other types of lymphoma and multiple myeloma. There are good reasons to think they're going to work also in Waldenstrom. So I think I'm personally excited about these two classes of drugs.
Hurry.
Yeah, and it's going to be a carnage because there are 3 different companies developing BTK degraders. There are 3 different companies developing bispecific antibodies, and it's going to be a lot of competition. We might run out of patients to participate in clinical trials in that specific setting. But yeah, I think those are the big ones, and I think the next one is obviously CAR T cells.
Absolutely.
CAR T cells have been really essential for the management of patients with myeloma, with different types of lymphoma, and I wouldn't be surprised if it does the same also for Waldenstrom's.
Shirley?
So yeah, I think the thing about BTK inhibitors as we have them now is that they have a few downsides over time. People may become less tolerant of them. Their disease may develop mutations in the binding site where BTK inhibitors latch onto BTK, and over time that can lead to resistance. So there are other drugs called non-covalent BTKs which bind in a slightly different way than the degraders that were mentioned. Act not by binding a site, but they act in an enzymatic way. So they bypass these kind of resistance mechanisms. So that I think is really cool, for want of a better word, and is well underway. There are a number of compounds in trials, and they're already showing really good, exciting results. Then there's the BCL2 inhibitors. So sonrotoclax is the sort of venetoclax successor, but it happens to be made by B1, as they're now called, which again offers just a different way of challenging the disease and can overcome people who are not responding to BTKs anymore. And I think the bispecifics are also really exciting. I've seen them more in the myeloma setting because that's when I look after inpatients, they have myeloma. And those drugs work by, they attack 2 things. So rituximab will go for CD20, but bispecifics will go for the tumor cell as well as the T cells. And they harness the T cells to actually help kill the tumor cells. So they're kind of a double whammy for the disease. They come with some challenges, so that is what the focus of trials is now, how to manage some of those like cytokine release syndromes and so on. And I think we're a little bit, hand-me-downs. We are waiting for the correct bispecifics to go into trials. There's some have started, but we're learning meanwhile from the other disease types. And meanwhile, we optimize some of these complications. When we get them in WM, we'll be all ready to go. I'm a little more circumspect about CAR T. I think it's quite, it's very, very exciting technology, but in a disease like WM, which is quite slow and gradual, I think we need to really sit tight and wait for some decent evidence, and I think it's something that should be offered later at the current time, if at all.
Shirley, on that point, just from the myeloma lessons on CAR T cells, there were the CARTITUDE studies that were done, and I've been going to all these myeloma CAR T meetings because I've wanted to learn, and how it can relate to our practices. But I was impressed with the fact that the CARTITUDE-4 study in myeloma showed, in fact, that there was benefit. They used this BCMA CAR T, but it looked like the drug was actually more active if it was given earlier when the immune system was still pretty strong. Admittedly, we need to do the clinical trials, but do you see sort of on the horizon that maybe CAR Ts will have a role, maybe in a select patient population, high risk, for instance?
Yeah, I think for sure. Especially maybe, the TP53 guys. I think there is this concept where with CAR T, you need the T cells to be, they're engineered to act against the tumor. So if your prior therapies have really exhausted the T cells, then like, as we've mentioned, bendamustine kind of damages the immune system B and T cells quite widely. These things do influence how CAR T may then work in the future, or even bispecifics, these engagers. So I think people are looking at ways of kind of reviving the T cells before going for CAR T. So the sequencing of therapies, the timing is also important. But we must remember CAR T is, I mean, there are some so-called off-the-shelf CAR T products, but some of them do need to be made specifically for patients. But I think in a very guided, careful way, an algorithm which defines high-risk patients using the right targets, I think I'd love to see them in action, but I think we have a little way to go.
Okay, good answer. I see a question and a microphone. Please.
Thank you. If someone is receiving IVIG or the sub-Q IgG replacement, but has had no other treatment and is now considering treatment, would you rule out the BNR right away because of a possibility of infections, as you mentioned?
That will not be a contraindication for me. If I felt that bendamustine and rituximab is the right approach for that patient, I wouldn't consider that a contraindication itself. I don't know what the rest of the...
I mean, if you continue the IVIG or subcutaneous replacement, that continues your protection. So I think that, assuming BR is the right thing at that point, I think you'll get ongoing protection from the IVIG.
Yeah, it's not uncommon for us to give IVIG for patients who are getting BR and have issues with recurrent infections, especially in other types of lymphoma. So it wouldn't be a contraindication to get a BR if you're getting IVIG.
Yeah, the only footnote I would just add is just the spacing between IVIG and rituximab, because these drugs do compete for the same receptors. So, you know, in my practice, I used to try to space them out by 2 weeks' time when they were administered, just so that they don't end up competing. IVIG can compete and actually potentially block the immune cells' receptors that are supposed to engage the tumor cells. So that might be the only caveat in utilizing Rituxan at the same time as IVIG. I don't know what your feelings are on that, if you have...
Yeah, we try to space them out.
Yeah. Okay. Any other questions from the audience? I see a lot of hands, which is wonderful. Whoever can get the microphone first.
Microphone
it looks
right
like
there.
you got it, sir.
Right.
Please.
I got it. Thank you. So my question has to do with effects of when to start treatment, the kind of treatment, specifically when you're talking about indirect effects of Waldenstrom. Let me give you an example. Typically, we look at treatment right now as qualitative. For instance, someone might have macular edema, or they might have night sweats or what have you, or quantitative, like they might have increased IgM levels or decreased or increased levels of edema. But what they typically don't do is say, I haven't heard of any tests where you'd say, what are the secondary effects that might be looked at? For instance, high levels of IgM have been known to cause systemic infections. And the systemic infection, systemic levels of high inflammation, I should say, typically could be causing hardening the arteries. It could be causing macular edema. And typically, a Waldenstrom's doctor would not think of looking at something like systemic inflammation that might, and then have them send you to some other doctor. And likewise, an cardiologist or retinologist wouldn't think of saying, if my patient has some of their issues, they should run a test that'll show them IgM levels or even CRP levels. So the question is, are there studies that are looking at secondary implications of Waldenstrom's that are not typically looked at because of standard studies?
Yeah, that's a loaded question to which we would need another Ask the Doctor session to answer. There are fixed criteria now that were developed as to when to start therapy for a patient, and that took into account some of the common morbidities that are associated with the disease. But this, I don't think by any means is that a complete, list of symptoms that might guide a physician to using therapy. It's a good question. I'm just wondering, you know, are there patients outside of the guidelines that we have, consensus guidelines for starting therapy? Are there any other considerations you might take into account as to when to start therapy?
Yeah, I think it's a really interesting question because in our practice, there's definitely a group of patients who have a sort of inflammatory phenotype, okay, and actually some of the European colleagues in France in particular are looking at the inflammatory WM cohort. For me, WM is a kind of, the immune system is switched on but also aberrant, but in some patients the inflammatory components are very significant, and I think that probably plays out with fatigue that goes beyond the hemoglobin level, which is often pervasive and persistent. I will, in those cases, look for markers of inflammation. So ESR is often very elevated when you have a paraprotein, so it's not very informative. But I will look at CRP, I will look for evidence, look at, obviously the IgM level, but also what I might do is send patients to, we have a sister hospital, which actually is the National Amyloid Center, but they have a sort of protein clinic, and I will ask them to assess the patient whether, for example, it's a bit of a crossover with Schnitzler syndrome, where there's this inflammatory overlay with a lot of chemicals floating around the interleukins. And sometimes they've actually given a trial of anakinra to these patients to see whether it alleviates their symptoms. Often they have muscle aches, they're very fatigued. So I keep quite an open mind. I'm very keen to explore the gray zones in regards to triggering therapy, because we can all, we can follow the kind of rule, but the longer I've been in WM, the more I stray a little bit away from those rules, because if you have a patient with a really bad quality of life, you feel as if you're being a bit cruel by just sitting on your therapy and saying, you can't have it, you know. So sometimes I will consider, I'm not talking about a very high-level IgM, but I will consider maybe 4 rituximabs as a sort of in-between thing. It's not a massive commitment of therapy, but it may offset some of the symptoms that are being generated by WM. But it's very case by case, and I will also explore, make sure there are no rheumatological conditions, and keep a very close eye on those patients.
Yasir?
Yeah, so there could be some, I don't think this is common, but there could be a few inflammatory conditions sometimes triggered or mediated by IgM. Sometimes we see kidney damage triggered by inflammation from Waldenstrom, not necessarily from just the IgM deposition in the kidneys, but there could be an inflammatory process. And that could be an indication to start treatment, even though the typical guidelines or criteria might not apply on that particular case.
Yeah, I agree. We do have this group of patients that sometimes have a lot of different symptoms, and it's unclear, that there's a relation with the IgM, but there's no other explanation either. So in those type of situations, I tend to, talk to the patient. It's like, we have not proven that your symptoms are clearly related to the disease, but we have not proven that it's not, right? So in those type of situations, I go by how the patients feel and how much the symptoms are impacting the quality of life of the patient. If the patient feels the symptoms are manageable, then we prefer not to intervene. But if the symptoms are not manageable, then we can intervene, but with the caveat that they need to understand that since we do not know for sure that there's a relation with the disease, whatever we give might not actually work to solve the symptoms. And as long as the patients understand the potential risks and the potential benefit, and that window is much less clear compared to when somebody has anemia or a high IgM, which is clear, the benefit, risk window, then sometimes we do proceed with treatment.
Yeah, I think fatigue is a very common symptom, but there are also other things that can cause fatigue beyond Waldenstrom. So it is really important to, in a very comprehensive way, make sure that there isn't another etiology for the fatigue.
And there are different levels of fatigue too, so.
Yeah, there's also physician fatigue too, but.
I just want to mention one thing.
Please.
And we're very keen, and we have done a pilot study on using wearable devices in WM to try and measure people's experience of living with the disease continuously through a watch and connected to a digital ecosystem. And some of you may have come to the talk we did yesterday on the preliminary outcomes of this. But I think this is one way forward. to get a clearer, to delineate the various factors that interplay and whether it affects sleep, whether you have fevers, sweats, whether your heart rate. So that is something we're looking to take forward, actually. And I think, I mean, personally, I'm truly interested in this because I see it in patients every week that this is something that bothers them. And I hope that these kind of studies will help to define these subgroups, like who might benefit from things now as opposed to later, for example.
Okay, we're down to 10 minutes, so we're going to take a couple of very quick questions, and Ellie's got the microphone, please.
As my husband well knows, I have a real rodent phobia, and I don't care how many mice have to give their lives to help us get to the cure. But I am wondering if AI, or artificial intelligence, can help accelerate the cure, and how you're using it for data collection, for example.
So let me pick one panelist to try to get through all the remaining questions. And who wants to volunteer for this one? Who wants to go first? Or only?
I'll have a go.
All right. Shirley's going to answer the AI question.
So I think, I mean, for example, in the methods we're using, there is a machine learning element to trying to pick out correlations with symptoms and the things that trigger further clinical progression or symptoms or events that are happening in the short term. I mean, it's all over the place, AI, but I think that's one area where you can use that to further our understanding. It also pops up in diagnostics. I mean, some of the pictures you've seen of the genetics, and I mean, that's all, a lot of that is AI assisted, where you can get massive amounts of data using AI methodologies. Radiology is another area. So it is actually all around us, but we want to harness it for more.
Super. All right. Next question, quick answer. Please, back there with the
Sharon
microphone.
has the microphone.
Oh, you have the microphone. I can't see from here. Please.
All right, this is a little bit of a two-part question. So first, what people treat, and then they go into, limbo lands. I call it vacation.
Vacation.
So, right, I call it vacation. But it could be remission. I don't know, some people use watch and wait. So there's a lot of discussion about that. Like people will ask, how long am I going to last till the next treatment? And I know we have research, but how would you answer that to a patient in terms of how long do I have? And then the second part is terms. The new one is functional cure. So some people that have been, let's say, 10 years out from BNR, let's just use that as an example, what does that mean? So I guess there's a lot of discussion about that in our world about in that limbo land till the next treatment maybe comes or a cure.
Okay, Jorge, you can have this one.
Well, I'll answer the first question, which is specifically, how do we predict how long the benefit of a treatment lasts? I think there are two different approaches, right? We do have the finite treatment approaches, rituximab-containing regimens, and then we have the BTK inhibitors. They're a little bit different. For rituximab-containing regimens, we tend to use, everything is imperfect, but we tend to use the depth of the response to kind of, get a sense of how long that benefit is going to last. So individuals who get to very good responses, meaning more than 90% of IgM, for example, those are more likely to have several years of benefit compared to somebody who gets maybe a 35% decrease in their IgM only. That's a minor response, and that will be probably not so much more pronounced. And again, these are groups of people. And I think that's an important message because from the physician perspective, what we see is a group of people, and we describe what happens to that group of people. But you as a patient, you're an individual, so what happens to a group of people means very little to you as a person because either you're going to progress within 2 years or within 10 years, regardless of where you are, right? So there's always a curve of distribution around that. So the estimates that we provide are just that. They're estimates, it's like when the advertisements for weight loss, right? These might not be representative of what happens to you. Something like that. So yeah, likely, if you follow.
So thank you for your short answer. Thank you. Okay, we got to get through a few more. There's hands over here. You have the mic. Okay, we're gonna wait.
Okay, I have
Make sure
two
we get one mic over here too.
Real quick question.
Please.
You had mentioned something about small fiber
Neuropathy. Yes.
I have small fiber, so I'm just interested. How is the WM or the IgM protein, if you already said it was kind of, how is it related to small fiber?
Yeah, let me tackle that if I may, because this is really one of the big unknowns as to the causation of small fiber neuropathy. And I know that in London, with Michael Lunn, you've been very interested in this topic, as you have you as well, Jorge. Yazir, I'm not sure at Ohio State how much excitement there is around this, but it's been very frustrating to treat patients with small fiber neuropathy. The way we detect this is by doing EMG studies, and usually with the other types of neuropathies, you get a signature that sort of gives you an idea of what the causation is. With small fiber neuropathies, you don't tend to see a signature from the EMG studies. And often we're left an unknown. We have to make this as a clinical decision as to what type of neuropathy there is. But treating this type of neuropathy can be very frustrating because even with the traditional therapies that we offer, we don't see really the impact on small fiber neuropathies. If anyone has a different answer.
No, I think that's absolutely right. And I think there's really very little evidence that WM directly causes small fiber neuropathy. So it's kind of alongside it. There may be a contribution. It's hard to measure. I wouldn't institute treatment of WM for small fiber neuropathy alone. I would focus mainly on symptomatic measures.
Yeah.
Yeah, what we are doing at Dana-Farber, which is nor here nor there, we're actually doing skin biopsies. In these skin biopsies, we can see the small nerves actually penetrate into the skin, and we do see 1 in 5 of patients with small fiber neuropathy having actually IgM deposition in the small fibers. In those cases, we may consider treatment. In most cases, we don't.
Super. I think there's a microphone over here right there, please.
I have a question that's sort of a follow-up to the question over here about when your treatment has given you a long remission or response. Even inevitably, you end up having to make a decision of what next. I had BR, and I thought, as I read for years now, you always go back to whatever worked the first time. Now I feel like maybe we need to be determining, based on all those mutations, that may not be the thing to do. So could you comment on that?
Yeah, that's a really good question. It can be very patient-specific in terms of the answer, but Yazir, would you like to take that one?
Yeah, in general, we don't like to use BR again, even though this rule in general applies to most other treatments because of the risk of low blood counts and the risk of other cancers. So it's very rare for us to use BR again. But for example, if someone gets rituximab alone, which is not uncommon for us to use these days, but if someone gets rituximab alone and they achieve long response, and then the lymphoma relapses or progresses again, that might be a good drug to use again. It doesn't happen usually with the BTKI because you stay on them for as long as it's working. But if for some reason they're stopped and your lymphoma relapses or progresses years later, that can be an option to use again.
Okay, we can probably take 2 quick questions. Somebody's got the microphone, please.
So you talked about the shingles vaccine during the BNR treatment. What are your thoughts on continuing on acyclovir rather than getting the vaccine? I've stayed on it since completing treatment in 2021 by choice, mainly because I don't like getting shots, and I've felt pretty good, so I just don't want to rock the boat. But I was curious what your thoughts were.
So just to sort of generalize the question, it's about how long would you keep acyclovir going after therapy? Mm-hmm. And what therapy?
I had BNR in...
Bendamustine Rituxan?
Mm-hmm,
okay,
in
super.
2019 to 2020.
Okay. How long would you consider acyclovir for in somebody who got bendamustine Rituxan?
So I think as a minimum 6 to 12 months, but we do look at the lymphocyte count as a guide to see whether if it's normalizing, then we would consider maybe stopping it. So, but it could be even 1.5, 2 years.
And do you speciate the lymphocyte count? Do you look at CD4 count?
Yeah, we would then maybe look at the CD4/8 count just to see what the level is. It's a bit of a blunt tool, but better than nothing.
Anybody have a different answer? Nope. Okay, last question. Last question. Somebody's got the microphone, please.
Thanks. You mentioned earlier today that bendamustine is at least associated with longer-term toxicities and/or secondary cancers. I'm wondering if there's any data recognizing that some of these other remedies are newer drugs. Any evidence along those lines about the BTK inhibitors or venetoclax, or if not, is there a theoretical basis one way or another to believe that they will or won't have such effects?
Yeah, that's a wonderful question. So time is always very important for these kind of studies. You need to see enough time go by to see if there's events. And with BTK inhibitors, there was this upshot of skin-related cancers. But what is always difficult in the background is that patients with Waldenstrom's as well as CLL, our cousin disease, also have an increased risk of skin cancer that just may be related to their background in genomics. We see also, other cancers in the population of Waldenstrom patients, and there's a background that exists because we all get older, we become more susceptible to cancers. I think the general message to take home is being able to sort out the general risk of cancer versus treatment-related cancers is sometimes difficult, and that's why you want to have these kind of controlled studies going forward. The bendamustine Rituxan study from the French group was very informative because they had the long-term follow-up. They reported on the other cancers. But Jorge will tell you, because he's also studied sort of associated cancers in Waldenstrom patients, that there is a background there irrespective of whether they saw bendamustine rituximab. So those kind of studies are very important to put into perspective of what the general cancer risk is. If I have one bit of advice for all of you, and that is that you're focused on Waldenstrom's here today, but remember that you're also human beings, and that means that getting your general screening for other cancers is very, very important. Don't let down your guard, because many times it's the other cancer that comes along, which may not have to do anything with your Waldenstrom's or your other therapies, but it's just a general age-related risk. So be sure to stay on top of your screening, whether that's for skin cancers, men, prostate, colonoscopies for everybody, women, mammograms, but don't forget, because I've seen this in my practice many times where it turned out to be a different cancer that came along and could have been preventable because of screening that should have been done. And I think with that, we're going to end the Ask the Doctor session. I want to thank our panelists. And now it gives me great pleasure to turn the program back to Paul. I know we didn't get to all of the questions, but I think our panelists will be around. If anyone wants to approach any of the panel members, I'm sure they'll be able to answer your questions. And Paul, this was really a very exciting and fruitful meeting, so thank you to you. Thank you to Cindy for helping to put this conference together. Thank you to all the board members who helped make this very successful meeting possible, and we should give all of them a round of applause.
I promise I'll have you out of here in 7 minutes, and 7 minutes will give us 3 minutes ahead of when this is supposed to be finished. So I've been consistent the whole. So patience, please, and I've got one plug, and I have to say thank yous to so many people. So I've been requested so often in the last 3 hours, and I've drafted this for you. In 1999, the IWMF started doing research. First time. That's 25 years ago. Every single person who has WM, every single person whose family has somebody with WM has benefited from that. We are the winners because 25 years ago, some people made an effort. They made donations. It turned out they had breakthroughs, And therefore, the 200 people that were at this conference were the winners. It's pretty self-evident to me that everybody who wins from someone else's selflessness has something to pay back. And I think that's very consistent with the spirit of this. It feels like a family, and we are in a family. And we're in the family of WM, and the only people, no government, pharma to a very minor degree, is going to help us out. We are depending on WM patients and their families. It matters not to me if you give $5, you give $5 a month, you give $25 a month, or you undertake a research project. But I believe that I have the responsibility of doing what Paul Kitchen can do to donate to make a difference, so that my next generation will have, somebody will have WM if my mother did and I did, and I'm going to make sure that that next generation does not. A little bit, we're planting trees, and when you plant an oak tree, you never plant it for yourselves, you plant it for the next generation, so that beautiful tree's there, and we're doing the same thing for WM. So I just wish you would go away. Whatever it is, it doesn't matter. I love the support that you've given the IWMF this week, the warmth, the care, and I think we have another portion that all of us can make a contribution to. So thank you. I'm proud of you. I've been delighted with this whole conference. I do have some things I just have to say on the way out. There is a survey that goes with those who have the app. Those who do not have the app, there will be an email to you later today with a survey about this conference. Please don't particularly be nice. If we deserve it, go ahead. But if there were things that could be better, please tell us, because we want to make 2026 even better than 2025. I have so many thank yous, so if you could just put up with me whilst I do. I have a partner in crime, and she's standing right here, and her name's Lisa Wise, and she's really sick, and we're supposed to be doing everything together, and we were supposed to close this conference together. So to Lisa, we love you, get better, we need you on our board. The staff of the IWMF, I spoke to them on Thursday morning. They've come through in fabulous, every single one of them's here. They've done everything they can to make this conference great. The hotel staff has bent over backwards, and I am thankful and appreciation. The audio-visual people at the back of the room have handed out mics and been great. Our sponsors help defer. Doesn't pay for this conference, I assure you, but it helps defer some of the costs, so thank you, sponsors. The doctors and researchers are all here on their own dime. Nobody is being paid. All those folks have given up weekends and given up time, and they've got here. And it's a gift to the IWMF. And I think all the doctors appreciate it. That magic group I was talking to you about, the WMNet, they had meeting yesterday and the day before, and they're all in the background here. So that WMNet is going to make a difference to our clinical trials. They're here. The IWMF has support group leaders here, affinity group leaders here, and global partners. And they've all come to be volunteers and to do the things that we have to do, they have to do, to make the IWMF work. So thank you to all of you. We have hundreds of virtual attendees. You are an important part of this conference. Thank you for being there. Next year, we're going to be in Columbus, Ohio. People have said it's sort of a peculiar place. Very easy place for an extremely large population to drive to. It's one of our considerations is that we can make this as inexpensive and as cooperative as we can. So we'll see. So we would love to see everybody on May the 1st, 2026 in Columbus, Ohio. But most of all, thank you for being here. What a wonderful conference. You guys are great.